Welcome back to Secrets of Beauty and Wellness, and I am your host, and today I have two guests with me. I'm so excited. I have Vivy from Vivify Aesthetics in Lake Nona, and then I have Lindsay Manzlak. Did I say that correctly?
You did.
Yay! And she's a women's health nurse practitioner, and I kind of want to make this episode so we can talk about women's health, and I want to talk about the pains and this misconception that we have about hormones, and I wanted to make this as interactive as possible to give you guys as much knowledge as can. So I'm gonna open. Lindsay, do you want to say something for our guest?
My name is Lindsay Manzlak. I'm owner of Wednesday Wellness. I'm based out of Newport News, Virginia, but serving all of Virginia through, the option of telehealth, which is so great to be able to expand our reach. But very passionate about women's wellness. Have always kind of been in that realm. Not actually in that realm, but still finding ways to incorporate wellness, whether it was in even GYN oncology or primary GYN settings. And so it's neat to be able to focus solely on optimizing women throughout the lifespan, but specifically within perimenopause and menopause. It's something that is gaining a lot of traction, thankfully.
Finally.
Yes.
And we haven't given it much attention. And so I'm so happy to see so many women leading that. And I think it's only going to get better for our sisters and our daughters. And it's just the care that I wish that our moms would have had.
I think we're just putting that set in stone. Like, people need to start educating themselves. Women need to start learning about the importance of hormone replacement, because I think there's a huge misconception when it comes with hormones. And, I've been doing this for, 9-10 years now, since 2016. And every time I would say hormone replacement, they would look at me like, no, I don't want breast cancer. I don't want ovarian cancer. I want a uterine cancer. Talk to me about your experience in women's health. What would you tell someone that's telling you, I don't want to be on hormones because I'm afraid of breast cancer?
I think that there was a study done over 20 years ago that was, when you're looking at studies, or when you're looking at headlines from things that are reported from studies, you don't really dive, as a layperson, you're not really diving into how that study was actually designed. And so this study was performed on women that were past menopause by a number of years, and it was using medications that really we're not using in practice currently. And it kind of lumped these results together, and it was a sort of poorly designed, even more poorly reported study that kind of scared all prescribers away from even considering hormone replacement. And if you look a little bit further into the data, the fears can be disproven. There's a book called Estrogen Matters that kind of dispels a lot of those myths, but it's a really, really hard thing to try to combat, because as soon as something takes off in mainstream media, it's hard to kind of rein it back in. And also, as a result, entire generation of doctors wasn't trained because everybody was scared of hormones. And so when people say oh, it's not, I want to do it naturally. Well, it's not natural to outlive your ovaries, right? Women died in childbirth, and our life expectancy is thankfully a lot longer. Yes. And so we don't know, data on living without your hormones for 40, 50 years.
You spend a third of your life in menopause. This is a lot of years that you are on this state. Why not live the rest of your life with the hormones that you need to avoid chronic medical conditions? And that's the thing about the Women's Health Initiative, that the way that study was segmented, in my opinion, wasn't done properly, because they had a lot of women that were postmenopausal for more than 10 years. And you had that window of 10 years to be starting on hormone replacement to get the benefits and the protection of the estrogen, which I think is such an important hormone for females, regardless of where you are in life. But I think when that headlines came out in 2001 that, hormones cause breast cancer, and everybody just cold turkey stop hormones, I would never ever do that to a female, and then they're living the next 20 years in pain with, brain cancer, with Alzheimer's, with weight gain, with high cholesterol. Like there's so many symptoms that a woman can experience when you're on perimenopause and menopause. Then we should not be living like this. And it makes me so angry that we have lived the past 20 years without hormones.
Yeah, I mean, and we know that the protective benefits of estrogen being anti-inflammatory, and knowing from a cardiac standpoint, of course, like nobody wants breast cancer, and that's one of women's main fears. However, the true number one killer of women is cardiac disease. And if there's something that we can use to help prevent that, and not that everybody needs to be or should be, or, it's not everybody should be on hormones, obviously, like individualized decision making, but getting accurate information out to women so that you can make an informed decision for yourself, and looking at your whole picture and not just this cookie cutter medicine. I mean, we're as different as our faces. And so to not make broad sweeping generalizations about who should and shouldn't be on it. But there's a lot of providers that were never trained on it. And so it makes it hard for patients to even sort through like where to get your information.
And I think, I can't blame physicians or even OBGYNs that aren't trained on menopause and how to treat postmenopausal females. Is because they haven't been educated. And I follow Dr. Mary Claire Heaven, which I think everybody does follow her, everybody knows who she is. And she advocates a lot on this. And she always says, I wasn't trained. I did not know how to treat the symptoms on females. And I read her book. Her book is amazing. It's called The New Menopause. I think everybody should read that book. And when I get a new patient in consult, always come in for the same symptom, which is weight gain. And I always tell them, we need to check your hormones. This is probably a hormonal imbalance that we need to, fix before we get you any other medications. And I always give them an assignment. I want you to read The New Menopause book. I want you to read The Menopause Brain, and I want you to read Estrogen Matters. And that's one of my first assignments to my patients, and actually give them a copy of the book because I really want them to read it so we can have an educated conversation about whether HRT is an opportunity for you.
Yeah, I think there's a lot of rarely are you taught about the things that are going on in your body. Nobody, I mean, you can go your whole life without knowing what hormones do what. And
yeah,
it does women a disservice. And so if we're doing these education, I personally within my community, because I know that I'm not accessible to every person, I'm big on like making sure that I offer free education just so that you can be armed with like actual factual data and knowledge about things that to us are basic because we've been doing it for many years. But for women that, let alone like in a normal cycle, when everything starts to go haywire, you need to have some kind of understanding so that you can come to your appointments with whatever provider that you're seeing and be able to kind of speak intelligently to some extent about the things that you may need, and just trying to have that conversation. And I think that we'll get there. I also think that like there's not a lot of money to be made in menopause within the conventional healthcare setting. And so it's hard to take the time that you need, and insurance doesn't want to pay for that. And so that's not where the intention is. And that's a whole different conversation, but it's a real thing.
It is.
Yes.
Women kind of turn to the internet, and then you don't really know like how to sort through, who's trying to sell you what and what their credentials are. And unfortunately, I think that there are people that kind of count on that and know that women just want to feel better. And it can make it really hard to know like where to focus your attention and where to place your trust.
I always tell, listeners and followers to kind of put down on a piece of paper all of your symptoms. It doesn't matter what it is, just put it down on a piece of paper and take that symptom list to your provider. Because if you go to conventional medicine, all you got is 10-15 minutes. So make the most of those 10-15 minutes and share what you're experiencing, because it hurts me when I get patients in clinic and they're like, I've been to so many doctors and endocrinologists and gynecologists and PCPs, and No one can help me, and no one do a comprehensive blood work panel. I do. I am very, very high on that. I need to make sure that we're checking from A to C, because what if your hormones are unbalanced and this is the reason why you're feeling this way? And a new symptom that I recently learned and by studying and going to conferences is tinnitus. I didn't knew that was a symptom of menopause. Like I'm still learning. I'm still educating myself to be the best provider that I can for my patient. But that was something that I was like, I would never ever guess that. And then looking back, when I was in traditional medicine, which I did for many years, I dismissed so many women that were coming to me for that reason. I don't know where I'm having tinnitus. Oh, you're fine. Go to ear, nose, and throat, and they'll figure it out.
Everybody's symptoms present a little different.
Yeah, and I do, I feel so bad that I wasn't listening, that I wasn't honestly doing my best for patients. And I think now I'm taking this on me of trying to help as much as I can, because I didn't in my beginning years.
Well, when you know better, you do better. That sort of mentality,
It gets better.
Yourself and say that, like not many providers will actually humble themselves and say, I don't know, or you may not know, but like here's a referral to somebody that has the time and energy and knowledge.
And I was afraid, honestly, of hormones when I went into school and they teach you all this. And the first thing they tell you, give them the lowest amount of hormones for the lowest time possible. And that was always my mentality when I was doing primary care. And I was so afraid of giving patients hormones. I'm honest, I'm gonna admit that I was very, very afraid because I did not want them to get breast cancer. And it wasn't until I sat down, and this was during, actually in the beginning of COVID, when I kind of took a sabbatical and I said, I'm just gonna go into functional medicine, and went into functional medicine because I wanted to learn, I wanted to serve my patients better, because no one is getting better. I'm giving you medications over medication, and you're still coming back and you're still overweight, obese, with hot flashes. Why am I doing wrong? So I wanted to learn more about how to take care of my patients.
Well, yeah, and also touching on the fact that like there's a lot that you as a patient can do outside of an office, as we know, and a lot of the stuff is like very, very basic, all the things that we know, but who is actually doing it consistently. And again, it doesn't make money. It's not sexy to say like, go for a walk and make sure you're eating vegetables and you need to go to sleep. Like, no, okay, you need to be a professional nag, you can't sell that, but those are the things like when you find yourself looking for the next solution, really be honest with yourself about what you're actually doing from an overall health standpoint, because all of those things are going to impact, even if you are on hormones, they're going to impact how your body is able to respond to them, because the whole inflammation piece to things, we're not addressing that. No amount of hormones can compete with that.
No.
And so again, it kind of falls on deaf ears when you don't feel validated, though, to incorporate that. And so taking the time to validate patients' symptoms and piecing it together for them, because a lot of times it takes women.
We're detectives in here. We have to be detectives and find out what is going on. My questionnaire have gone from 1 page to almost 6 pages now. When I get a new patient, like I'm asking all these questions that might look silly to you, but they're telling me something. And they're like, do I have to complete all this? Yes, you do have to complete all this, just so I can have a better picture of what is going on with you. Because like you said, sleeping is so important for anything and everything in your life. And if you're not sleeping good, and I ask that question, how long are you sleeping for? How many hours are you getting? Do you wake up at night? Like an average, how many hours? And like all these questions, yes, all these questions is what I need. And piggyback on hormones are not everything. If you're not, sleeping or drinking water or eating your vegetables or eating enough protein or exercising, it doesn't matter how much hormone I give you, you're still not gonna feel at best.
There's no magic medication or anything. And as much as people want that to be true, like benefit to like having some skin in the game and knowing that you had your part in it. And it feels overwhelming at times, but then also knowing that the things that you're doing have a lot of benefits in different ways. And so you're getting like more bang for your buck by making sure that you're getting good sleep. And, and I think too, a lot of women go their whole life like struggling in one way or another. And that's just kind of normalized. Like, oh, you're a woman. This is hard. Of course it's hard. It's hard for me. It's like, and yeah, like you get to a point in perimenopause and menopause that like your body forces you to pay attention to itself, and you can't just plow through a day. And that can be a really good turning point to say like my health, my mental health, my like any facet of your life, like that matters. And you have to pay attention or you're not going to be able to function. And for some women, that's the first time in their life that they can speak up and say, like, I'm paying attention to me. And so reframing it to where it's not this like thing that you dread, but saying like, I'm using this as an opportunity to, use the next however many years of my life to live as well as I can. And
Yeah, as good as you can.
Comfortable and yes, not suffering in silence.
What do you say to patients that are like, I know I need HRT, but BRCA positive? Like there's this mentality that if you're BRCA positive, you can't be on estrogen. Like how do you combat that from a patient telling you this?
by telling them that that's not like a contraindication. There's women that have a history of breast cancer, and obviously that's a much more nuanced conversation. But gone are the days where those like total no's to certain options for treatment. And I think there's a lot of assumption from patients that say like, oh, I have a family history of that, or I am, BRCA positive. But if you have risk reducing surgery and you live for even longer because you had your risk reducing surgery early on in your life, like you're trading one problem for another from a bone health, cardiac, mental health and brain health and all of that. And so I think that it's hard to get those people even through your door because it's so deeply rooted. But if you can, then having intelligent conversation and doing your homework to be able to counsel patients effectively.
And I tell them, you might be afraid of systemic estrogen, but there are some other options. Like if you're having vaginal dryness, I could give you, vaginal estrogen, and that should help you with your symptoms. You're having, frequent UTIs, because a lot of patients don't realize that frequent UTIs can be a symptom of low estrogen. And I always say this, if I can save someone's life from dying from sepsis, I want to. And I hope this goes to someone that's having frequent UTIs so they can say, I want estrogen intravaginally, because it helps so much, and we can still treat the local area without having to go systemic if you're truly afraid of being on systemic estrogen. I don't know how will you treat that, but that's just the way I like to do here in my practice.
To your point about asking those lengthy questionnaires, people might not, women may not piece those symptoms together, but knowing what we know and being able to look at things and zoom out and then zoom back in and say like, all of this is related, whether you think so or not. And yes, we know that this is a very, very safe, very underutilized treatment for this, and this, all the things that you touched on. And also, nocturia, where women are getting up in the middle of the night because they have to pee and then they can't get back to sleep. And wow, if I just use estrogen vaginally twice a week at bedtime, that can help with that. I think that a lot of women are blown away by all the different applications of even something as simple as vaginal estrogen. And it should not be on just GYNs and menopause specialists to be prescribing it. I mean, primary care doctors can certainly, it can and should be offering it to people.
They should, but the knowledge is not there. I think that's a problem. They just don't know how to treat this. And they, piggybacking on the whole primary care doctors, I don't think they have the time to sit down and talk to you about your symptoms. And yes, you're going through perimenopause and menopause, and this is what you need to feel better. They're just here's a referral for a GYN. You have to wait to see the GYN. And it's just, The healthcare industry, I'm not a fan of it. And here in the United States, because it's like you need a referral for everything. Like, why can't you just help me because you're my primary care? Why can't you just help me with my symptoms? No, go to gynecologist.
Well, if we get the black box warning off of vaginal estrogen,
I saw that. I was so happy. I saw the news last week, and I was like, finally, things are changing, and I love where we're going with this. No more black box warning. So excited.
How did I miss that? I'm embarrassed to say that I missed that.
Yeah, that happened. We don't have a black box warning anymore.
I've been so busy, like business-wise, practice-wise, momming-wise. I feel like that should be everywhere.
I actually saw it on Dr. Mary Haver's Instagram page. This is the thing when every time I'm driving my car, I don't listen to music. I actually listen to podcasts, and I always go to YouTube, and I just say, okay, what's on my home? Oh, this sounds interesting. I just play and I just keep driving or cleaning the house. That's what I do, and that just happened last week, and it should be everywhere. I think it's everywhere. No, okay, so we used to have a black box warning on using vaginal estrogen. Now we don't have that anymore, which means that more patients will not be afraid of using vaginal estrogen, which is pretty cool. I think it's a step into dealing with the symptoms of menopause and patients being more empowered of making the right decisions for their health. Because being in menopause, as you're going to perimenopause, aren't you?
I would admit, yes, I'm in my mid-40s, and so perimenopause is not fun. No, these symptoms that go with it is like, how do I control this?
We have so many symptoms in perimenopause, and I actually had a patient, I think she was at the time 38 or 39, and she came to me saying, I don't know what to do, because I've been to all these doctors and my blood work is normal and I'm going through all these symptoms. And I'm like, you can most likely be on perimenopause at 39. Yeah. Like, that needs to be told. People don't believe that. No, you're not on your 50s. You can be perimenopause. You can start having symptoms of perimenopause 10 years before you actually last menstrual cycle.
Right. And the average age being 51 and a half in the US, like that means that half of women are younger than that. And if it happens 10 years, that your symptoms can start up to 10 years before then, it can be hard to sort out too. Like if you're having your babies later and you're postpartum and then you kind of just slide right into perimenopause, like it's very hard, let alone just like living your days.
But she was having all the classic symptoms. Like, how can you miss that? Like, she was, of course, the weight gain, obviously, but she was having hot flashes and she was waking up at night and she was out of nowhere, I'm depressed and I'm anxious and I'm on all this antidepressant. She was on Xanax 0.5, which is crazy to me, and she was on Effexor as well. And I couldn't understand why you were on these psychiatric medications when you actually just needed a little bit of help. I actually just put her on progesterone and she started feeling so much better. All she needed was progesterone, not even estradiol. And it made a huge difference for her, and she has something a lot of her friends coming over. But that just kind of taught me that anybody can start having symptoms, even at 39 years old. Have you had patients this young?
Oh, yeah. And I think that they just are just so exasperated with how they are trying to trudge through a day that they're willing to listen and are so grateful when pieces are put together for them. And then you give them micronized progesterone, which is kind of, we refer to it as like nature's Xanax for most women. You do get that like calming effect and it can really help you get sleep. It's a game changer between that and, the right supplements from a magnesium glycinate standpoint.
I love magnesium. All my patients know. Team magnesium.
The thing I start with from a sleep standpoint, if you're not sleeping well, you're not going to be
producing hormones anyways.
And I just started myself, so it's amazing. It's helped me a lot.
Magnesium is the best in I'm not in my 40s yet, so I can, speak for that, but I always tell patients, magnesium should be on everybody's supplement list, in my opinion. I think everybody can use magnesium because it has so many good benefits, and sleeping is a must to be on magnesium. And progesterone, I love progesterone, and I think the majority of my HRT patients are on progesterone. And I actually had a patient come today that she was like, but I don't need progesterone because I don't have a uterus. And I'm like, no, that's not true. We still had that mentality that I don't have uterus, I don't have to have progesterone. And you're missing on all the benefits.
Right. You don't need it, but you could still benefit from it. And doctors, for whatever reason, just training wise, but like just because you don't need it doesn't mean you can't have it and benefit from it.
I think everybody should be on it. Do you have patients with testosterone?
I do. And they are doing so well.
I love it though. I really love it. And I kind of wanted to get into testosterone a little bit because, again, a lot of patients are afraid of being testosterone because they're always thinking this is a male hormone. But this is not just a male hormone. We actually produce more testosterone than males. So that's crazy.
What's interesting too is your husband will have more estrogen than you after you go through menopause.
And people don't believe that. It's crazy.
Testosterone for men and estrogen for women, like, did women a disservice in that way. From a testosterone standpoint, I think that, knowing that it starts to decline in your 30s and it can be up to, half of what it is by the time that you're 40. It's no wonder that the symptoms that are associated with low testosterone are so common, but people are afraid to prescribe it. And then patients.
Oh, I'm not. I'm like, you need testosterone. Everybody gets testosterone.
Right. But even pharmacies will be hard, hard pressed to.
They're not covering it. I haven't had luck getting it covered.
Right. And there's ways around like prescribing it in a safe way, in a way that makes everyone happy from a pharmacy to a patient to a provider standpoint. But I think a lot of patients, if they run up against a provider that doesn't feel comfortable with it, end up going like the pellet route. And sometimes that takes you from 0 to 100 and you don't need.
I don't like pellets.
A lot more, harm than good in a lot of cases. And then that's what gives testosterone like the scary name behind it.
That's a topic for me for 40 more minutes because I don't like pellets and I wasn't sure if you do or don't, which is why I didn't bring it up sooner. But I don't like it. I'm not a fan of it. And I say this very loud and clear. My patients know that I don't do pellets. And they call me, I'm sorry, I don't do pellets. I hate not being able to control. So once I put your pellet in, that's it. It's in. I can't get it back. And I guess my OCD won't let me do pellets because I can control it. Like I can control everything else. I can control patches, I can control oral, I can control injection, I can control all that, but not pellets. I don't like it. It's not for me or my patients.
I mean, if there's not good data on the safety in terms of dosing and you're not, there probably are very skilled providers that can use them and it's not this, roller coaster, but I think that people capitalize on the fact that they can make a lot of money doing pellets.
That's the thing. People can make money out of it. Pellet is a more money maker.
One, two, like we know using like the topical testosterone, it can take months for you to feel the full effects of that. And so it's really hard to compete against like, oh yeah, we'll get you feeling better in a matter of weeks. But in that, my argument is like slower, just like weight loss is.
It is slower is better.
Don't go too high too fast.
Yeah.
And then in the meantime, while you're waiting for this to like fully kick in, you can work on the lifestyle things that you need to be working on.
Regardless of hormone or no hormones, you need to make changes on your lifestyle.
And so, when they're getting more consistent with all the things that everybody knows is good and having that accountability from the provider that's monitoring your testosterone levels and all of that, it works beautifully because you're having that accountability and that time that it takes to get consistent with things that you've not done for your entire life. So, and then by the time that you're, consistent with it, then you're getting the full effects of a healthy testosterone level without the side effects.
I had a lot of patients that come from pellets and they're like, it was working beautifully in the beginning and now I have no effects. But I still look at their blood work and testosterone is so high, yet they don't feel the benefits of testosterone anymore, but they're coming with hair growth, with mood swings, and with a lot of acne. And I'm like, we need to detox you a little bit from testosterone and let's start lowering your dose. Because the thing about pellets, testosterone tends to go very high. And I can't deal with that. But again, people feel better on pellets very quickly compared to topical or even intramuscular, because sometimes I do use intramuscular testosterone when it is needed for patients, because not all of them want to have a cream. But I am a fan of testosterone. I just think it needs to be done safely, and should you go to someone that knows what they're doing.
Yeah, and I think pellets have a place. Like if it's, if they're prescribing, the right amounts, not going too high too fast, because then you have to wait for that to kind of wear out. And then you're, depending on what symptoms or adverse effects that you're having from like a higher dose.
Again, if you're on pellets and it works for you, that's fine as well. I'm not gonna say anything about it. I'm not gonna take you off of it, if you want to be on pellets, but I don't do pellets. I don't prescribe pellets. And that sometimes that very hard conversation, because I get a lot of patients that I find you on social media. I love your videos. I love that you know about this. Can you prescribe my pellets? And I'm like, I'm sorry, I don't do pellets. And then that it becomes a difficult conversation with patients when I tell them that I just don't like to prescribe pellets.
Well, and to your point too, like if you are trained on the dosing and it is, done in a way that you're not having these huge fluctuations, like they do have a place. I say never, but I just haven't put my energy into learning that, because right now the things that we're using have been working. But
Correct.
Like I said, never say never. Come back to this podcast in however many years, and I'm doing that.
3 years down the line, now I'm saying I love pellets. Oh my God forbid. No, I wouldn't.
I guess like somebody coming to you in their perimenopausal state, what does that look like for like your clients coming in? Like how do you present it? And
so I think a lot of times too, women don't want to have a label on perimenopause, and there's some women that completely own it and they'll have like menopausal across the sweatshirt, and some people just like don't even want to admit that they're having a hot flash, but they're definitely struggling. And so kind of getting an idea of like what this time of life means to them, like what connotation it has. I think that's a really good starting point. I think also like, what are the things, like if I could change, obviously you're probably coming with a whole laundry list of things by the time you get in front of me, but if we could change 3 things in the next 6 months, what would be, the best for you? And going from there, like I said, a lot of times sleep is a primary complaint. And luckily for a lot of women, it is a fairly simple fix. And then you're like their best friend.
Yeah.
And they're telling everybody that they can, and rightfully so, because you can't function when you're not sleeping. And then obviously doing a really thorough workup of their past history and things, again, that they're not drawing correlations to, but that matter in terms of like preeclampsia in pregnancies or gestational diabetes or, family history that they may not even give a second thought to. Having the time to dig into things more comprehensively really does make a difference in terms of coming up with a treatment plan. And also, like you probably do, like setting expectations, like we're in this for the long haul. This is not just one visit. This is not even a 4-month program. This is like
12 months program easily.
Right. And this is not, in perimenopause, things are going to fluctuate, and we expect them to. And, some providers don't do labs because they know that. But I think that there's a lot to be said for going line by line with patients and saying like, there's no red flags here, but these are all the things that could be optimized. And this is what's going to make you feel better, and giving patients an understanding. And then again, putting it back on them in terms of like, what's your priority? Because I might have, 5 things that I think we should start with, but if your main thing is you just want to feel better in your clothes, like, okay, we'll start there. Or you want to, any number of things. It's so neat to see what brings women in finally too, and being able to walk alongside them as they prioritize themselves is like such a gift and a privilege.
All I want to say before we end today's podcast is that I'm so happy that there's a new movement that, women want to be empowered. They want to, be better, be healthier, and, ask for questions and demand for answer and demand to feel healthy again. And that's why I think this movement is amazing. I don't know if you're getting more clients for hormones, but I honestly think this is a good year, and it's just going to get better from here.
I hope so, because women deserve it. I mean, you spend your whole life taking care of everyone else, and if it takes till you're menopausal to put yourself at the top of the list, then so be it.
Make yourself a priority. Absolutely.
I would love to have you again because I want to dig deeper on the symptoms of perimenopause and menopause and what low testosterone looks like, what low estrogen looks like, what low progesterone looks like, because I know that can be another hour of conversation, which I love that, honestly. But I just want to thank you for being here with us today and just taking some time off your busy schedule to have this conversation with me, because it really means a lot. And I hope, this goes to a lot of people, that, it can help someone that really, really needs it. Thank you for listening to today's episode, and I will see you next week for the next one.